Greetings and welcome to today's masterclass session. I'm Lyle Laird, Director and Medical Science Liaison for Synovian Pharmaceuticals Psychiatry, and I will be moderator for this session. We're honored today to have Dr. Roger McIntyre as discussant. Dr. McIntyre's credentials and experiential base are indeed extensive. He is Professor, Department of Psychiatry and Department of Pharmacology at the University of Toronto. He's the head of the Mood Disorders Psychology Unit for the University Health Network. And he is lead or chairman of numerous other psychiatric societies and alliances. He is author of a multitude of scientific papers and chapters and is prolific as a researcher in the mood disorders. He is a recipient of a legion of teaching awards. He is an academic, a medical scientist, a psychiatrist, and a psychopharmacologist par excellence. I'm humbled to be here with him today as he presents and discusses the topic opportunities to improve diagnostic accuracy and outcomes in bipolar disorder. Today's agenda will address three main topic areas that are critical in the treatment of bipolar disorders. First, diagnostic accuracy for bipolar disorder. Second, the modifiable processes affecting bipolar disorder and its progression. And third, the dimensional aspects of bipolar disorder and how to prioritize them as the treatment plan is formulated. So let's get started with the first question. Dr. McIntyre, what are the diagnostic challenges associated with bipolar disorder?
Well, first of all, Lyle, thank you for that introduction, and thanks to all of you for joining us for today's session. And I want to just first of all acknowledge that in the aim towards improving health outcomes in bipolar, job number one is to get the diagnosis accurate and timely. And that then segues into my answer. The timeliness and the accuracy of the diagnosis remain unmet needs. I'm also going to add to that, Lyle, the problem we have with conversion or transition. In other words, many people with depression transition or convert into bipolar many years after the initial presentation of depression. For example, if you look at this slide that we have before us, what we in fact know is that people who initially present with a manic episode, they are more likely to be diagnosed sooner than people who are initially presenting with a depressive episode. This is not surprising. Depression is the predominant presentation of bipolar, it's the initial presentation of bipolar, and it's the reason people most often see care providers. So timeliness is a big issue. Too often also, Lyle, people are going into the care providers and they're not diagnosed accurately. They walk out with some of the diagnosis, often additional diagnosis. Today, it continues to be an unmet need. The third and final issue is this conversion or transition. What I mean by that is, and many of you in the audience would see that, is that in fact you see a patient who's depressed and then after 3 or 5, maybe 7 years later, they begin to have symptoms of irritability, racing thoughts, quite distracted. These individuals in fact are not responding to antidepressants. What's happening? Bipolar's now reached the surface. So they're transitioning now into bipolar disorder. And we need to be aware of that. That's not the fault of the clinician, that's just Mother Nature and how bipolar disorder is. So timeliness, accuracy, and be aware of the conversion.
Thank you. Would you please discuss complications in diagnosing bipolar disorder?
You know, this is so real to clinicians, and all of you in the audience here see this. Patients who have bipolar disorder have not only bipolar disorder to deal with, but they often have many concurrent conditions. And concurrent conditions can be of the psychiatric nature or medical nature. And experience has told me that often patients will come with a history of alcohol and or drug use disorder, other conditions like attention deficit hyperactivity. Other patients will present with psychosis. And certainly many patients come with other problems like thyroid disturbance or maybe even traumatic brain injury. They've had a medical injury to their brain. And these individuals often present in ways that are masquerading bipolar and or obscuring bipolar disorder. And what I mean by that is sometimes a person can have a presentation that mimics bipolar, which is better explained by the comorbidity, In other cases, the comorbidities is obscuring the bipolar diagnosis, or it's an additional diagnosis. So for me, I think that the major challenge we have in busy office practice is to be aware of the fact that bipolar disorder in many cases can be obscured by other conditions which are often in some cases demanding more immediate attention.
You just stated a second ago that depression is oftentimes the way the patient presents in their first episode of a mood disorder.
Correct.
So depression is clearly a commonality between unipolar depression and bipolar disorder.
Yeah.
This causes a dilemma, I think,
Sure.
for many clinicians. And how do they best figure these out? How can they tell the difference between the two?
Well, I agree with you, Lal. It is a dilemma, and the dilemma is made only more real by the fact that there's no item of depression that diagnoses bipolar disorder. The symptoms of depression and bipolar are identical to what we see in major depression, at least from a diagnostic perspective. So what I encourage all people to do is to think about some of the course validators. What does that mean? What's the age at onset? How many episodes has the patient had? For example, people who have bipolar, on average, tend to have an earlier age at onset and more episodes. The other part to that is the phenomenology. When compared to a person who has major depressive disorder, a person who has bipolar disorder is more likely to have psychosis, more likely to have reverse vegetative features like hyperphagia, hypersomnia, also more likely to have anxiety. What I also find very helpful, Lyle, is the pattern of comorbidity. Persons who have bipolar disorder, again on average, are more likely to have drug and alcohol misuse, binge eating disorder, and ADHD. That's not the exhaustive list because clinical experience also indicates anxiety, like panic, generalized and social. So think about these types of patterns and phenomenology. Finally, the whole topic of family history. Family history loaded for psychopathology. We know that genetically, bipolar 1 disorder is more closely associated with schizophrenia, and bipolar 2 disorder is more closely associated with major depression. So we often hear histories of psychosis, anxiety, depression, drug and alcohol misuse in people's family. One key point to emphasize as well, Lyle, is too often patients will come to us and say, I've been told I have depression and I've been prescribed many different antidepressants. They don't work and they make me feel worse. That history also gets you thinking about bipolarity. So taken together, the course validators, the phenomenology, the comorbidity, the family history, and response to treatment.
Would you say family history is probably one of the most important things to think
I do.
about? Yeah.
And if you said to me, Roger, if there's just one or two or three things, definitely family history, age at onset, and number of episodes. That's what I wrote. That's my sort of trifecta.
Thank you. So there can truly be subtle differences between the different presentations and between unipolar and bipolar disorder. How does a clinician ensure that an accurate diagnosis is made regarding bipolar disorder?
Nothing is more important than having reliable, factual information provided by a third party. This may be a family and or a friend or colleague who comes to the appointment, attends the appointment with your patient. The other part about this is having really good medical records. And I know that this is getting better, but still we have a lot of work to do. And what I'm looking for in the medical record is some of the things we talked about in terms of the age at onset, the response to treatment, and so on. But I have found over the years, most often patients come to the appointment on their own, and that's often a reflection of impaired interpersonal relations and so on. And when they do bring someone in, it really changes the complexion of the diagnostic history in many cases. And so I think this is critical to assist in arriving at that diagnosis.
Dr. McIntyre, please discuss modifiable factors that affect bipolar disorder.
What I'd like all of you to consider is that bipolar disorder is a condition that affects people differently across the trajectory. In other words, the illness usually presents in late teens, early 20s, and where it goes from there is very, very different between individuals. Taken together, what we have learned is that there are some factors that greatly influence the trajectory. Obviously, the timeliness and the accuracy of the diagnosis. We spoke about that, Lyle. Secondly is taking effective treatments. That clearly is a way to modify. But other factors are perhaps less well known. For example, obesity is one I've been interested in a long time, and metabolic problems, which you can see on the slide is very common. It's estimated that about 50% of people who have bipolar disorder have either obesity, dysglycemia, dyslipidemia, or hypertension. In other words, metabolic syndrome components. That in itself has its own morbidity, its own mortality, because cardiovascular disease is the most common cause of premature death in bipolar. But it's more than that, because we know that, as I always say, obesity metastasizes to your brain. And what I mean by that is, we now know that obesity creates a more complex, more severe, and more treatment-resistant depression, and people have more cognitive problems in bipolar if they're overweight or obese. And these are two critical complaints that lead to poor functional outcomes. So clearly we need to be managing not just above the neck, but below the neck.
So much has been said of metabolic disorders in psychiatry of late. How do they, or do they in fact fit in with bipolar disorder? Is this, you seem to implicate just a moment ago that there is a direct relationship.
Absolutely, and this is an area which has academic relevance as we try to unravel what is the underlying cause of bipolar disorder, or causes plural. What I've been very struck by is some of the studies that have been done in the unaffected first-degree relatives of people who have bipolar disorder. What that's telling us is the unaffected first-degree relative also has a higher rate of obesity and certain metabolic problems. So the first message is that metabolic problems are part of the illness.
Sure.
But added to that, many patients end up on medications that further disrupt glucose insulin homeostasis, further add to weight gain, and so on. And then some of the behaviors, quite frankly, add to this. The sleep disturbance, the habitual inactivity, the poor food choices, et cetera, et cetera. So taken together, it's kind of a combustible mix, so to speak, with respect to the hazards posed physically on people. But we really need to manage this issue because it's contributing to cardiovascular disease. And secondly, we now believe that it's changing the phenomenology. One impression that many clinicians have is that more and more bipolar individuals with bipolar are presenting with mixed features. This is the sort of combination of hypomanic and depressive features, and that may be more likely to be observed in people who are obese who have metabolic problems. And I bring that up, Lyle, because as you know, mixed features is the most severe, perhaps the most dangerous phenotype in psychiatry with respect to suicide risk. So this is not an academic point, this is clinically very relevant.
What about inflammatory processes? This is a topic that is gaining a lot of momentum.
Sure is.
And yeah, it interests a lot of folks. And its relationship to bipolar disorder, these processes, do they affect mood?
They really do. And the way to think about this, and the way I want all of you to think about this, is we now believe that inflammation may be causing, in some cases, bipolar disorder. Maybe it's responsible for some of the phenomenology of bipolar disorder, and maybe also the comorbidity. Let me say a few words about that. We know that people who have bipolar disorder, on average, are more likely to demonstrate through laboratory testing an increase in some of the inflammatory markers. And that's been understood in part to be causative of bipolar disorder. We also know that inflammation, when activated, can lead to some symptoms like fatigue or cognitive impairment, psychomotor retardation, to name some of the more common ones. And then thirdly, inflammation may explain why so many people with bipolar have, in quotes, inflammatory comorbidity: obesity, diabetes, migraine, inflammatory bowel disease, arthritis, the list keeps going. And so this is not just academically interesting, it's also perhaps shedding some light on how maybe some of our treatments work. I don't just mean pharmacotherapeutically, but also maybe some of the psychotherapeutic modalities like mindfulness-based therapy or social rhythm therapy. Maybe these therapies also have anti-inflammatory effects, and some evidence seems to suggest that. It also has inspired research looking at the role of dietary manipulation, etc. So it's been a very fascinating area, and it's been a very new way to shine the spotlight on this illness.
What about opportunities for clinicians in helping their patients with bipolar disorder?
You know, I think that the key thing when it comes to this issue about how we can help our patients I think it begins with a transparency in the diagnostic impression. I mean, that you should just tell the patient what you think that their diagnosis is. That may seem sort of obvious, but sometimes people don't feel comfortable giving people the diagnosis. Secondly, I also believe that patients do not have access to a surplus of accurate information. And so I think as care providers, as advocates of our patients and families, we also need to be the arbiters of accurate information on the diagnosis. There's lots of myths and distortions, and also around the treatments, what's realistic and what's not realistic. And I think that is, in an empathic way, with the patient as the self-manager, you as the consultant to the patient, I think that's how we help our patients best. Secondly, I think that we can also guide our patients towards important resources like advocacy. The DBSA is a well-known advocacy group, as well as where needed, the appropriate resources for concurrent conditions like drug and alcohol misuse. I have a lot of my patients go to the diabetes center or go to weight loss clinics and so on. So assisting the patient in, yes, mental health care, but also their physical health care.
From the patient's perspective, can you discuss unmet needs that patients realize when they think about bipolar disorder?
Sure, and all of you know that when you see lots of people who have bipolar disorder, what you often hear from patients is they want medications that are less likely to cause side effects, but maybe we'll come to that in a moment, but they also want treatments that are better able at helping their depression, treat and prevent, treatments that can help their anxiety, help their sleep. If you bring their loved one in or their friends in, what they're going to say is that, can you help this person with some of their mood instability? In other words, better coping strategies to manage their mood and also manage some of their day-to-day resolution of conflict and so on. And this is why I think so many people who have bipolar disorder do benefit from manual-based psychotherapeutic interventions. The other area that's been identified as an unmet need is really in the area of positive mental health, well-being, feeling well, having vitality, being able to sleep, being able to engage in activities. So I think when we talk to patients, we get a real list of unmet needs in the area of being themselves again, getting back on that normal trajectory.
How about choosing the treatments from the patient's perspective? What do they look to when they think about a treatment?
You know, it's interesting, Lau. We, as we should, be guided as clinicians by what does the evidence say, what does the science support, what's FDA approved, what are some of the guidelines suggesting algorithmically, and all this information informs our decisions. Historically, I don't think we've given as much priority to what the patient desires in the treatment, and clearly that's relevant. What you're looking at is a survey that was published by our group from the DBSA, looking at what patients with bipolar disorder, in fact, give priority to. It may not surprise anyone here, but side effects, weight gain, sexual dysfunction. Patients don't want to feel like fogged or sedated or like a zombie on medications. And this is a major issue. And I think it's also related to the fact that the medications can cause this, some of them, not all. And also I think that patients have an expectancy. They often don't want to be on medication, and there's an expectancy of untoward events, side effects. And so already I think that the person with bipolar typically is primed towards negative outcomes on medication. So we sort of want to add to that by giving them medications that cause some of these problems. Secondly, patients clearly want treatments that are recommended by us and treatments that are guided by good science. And I think that's our role, to be able to decipher what is the good science around the treatments and avoid the medications that have terrible side effects.
So how does the patient define what a good outcome is? What do they say?
You know, the biggest change that's occurred in my practice and my career, and I'm sure if I did a survey of our audience, it'd be no different. What patients, in fact, will say is, yes, you've taken away my mental health problems, but I don't feel healthy. In other words, the taketh away of my depressive or manic symptoms is not, in fact, actually resulting in me feeling well. I don't feel like I once did. I don't feel as inclined to engage with friends and family. And patients want to feel more vitality, get back on that normal trajectory. And this is part of a positive psychology movement where people now are spending more time talking about positive measures of well-being. And that makes sense to me. So this is why I think that for some patients, this is going to involve aspects of enhancing your social network of friends or contacts, being more involved in volunteer activities. For other people, it's involved in spiritual activities. The list goes on. And I think, in fact, engaging people positively is what patients give much more priority to. That doesn't mean we don't have an interest in alleviating depressive symptoms, but I think that other piece has historically not received the priority it should.
So let's move on to the final of the three areas, and this is regarding the dimensional aspects of bipolar disorder. Which dimensions in bipolar disorder should the clinician prioritize during treatment?
You know, I've been thinking about this for a long time, Lyle, in terms of what are the key dimensions of psychopathology that patients are so greatly affected by. And my conclusion is I think there's two significant enemies of the state. The first one is the area of reward, the anticipation of pleasure as well as the experience of pleasure. Too often patients, despite having good education, these are persons who, in fact, just cannot engage. They cannot engage psychosocially, occupationally, in the family, and often just live a fairly inactive life. That reflects a problem in motivational tone. We call that affective forecasting. Forecasting the pleasure to the future is what drives us as human beings. Secondly is the experience of pleasure. People, in fact, just feel pretty blah. They don't have much in terms of sense of color and experience of their life. Secondly is cognition. Too often patients say to me, you know, Dr. McIntyre, my mind is slowed down. I can't organize two thoughts. I just can't seem to keep not only my behavior organized, but my mood is just all over the place. That also is a cognitive problem. So I think that dimensionally, the two key targets for us are to help patients in these areas of motivational hedonism, experiential hedonism, as well as, in fact, in the area of cognition. This translates directly into quality of life and function. And we've talked about this. These are the unmet needs in the field. Too often patients, their mania or their depression resolves, but they have not returned back to trajectory. They're still off trajectory in terms of function. And this is largely because of these two dimensions.
Well, thank you so much for this discussion today, and I want to thank the audience for their attendance.
Thank you, and thank you, Lyle, for hosting, and thank you all for joining us at this meeting today.
Thank you.